All right, everybody, good afternoon from here in the Eastern time zone. Good morning to those of you across the country. This is our virtual education session themed around ultrasound. I'm Brad Sobolewski, current chair of the AAP Section on Emergency Medicine Education Steering Committee and the Education Subcommittee. And this presentation is entitled Advancing POCUS in Pediatric Emergency Medicine Education, Implementation, and Quality Assurance. Presented by the Education Subcommittee and the POCUS and Pediatric Special Interest Group, both of the AAP Section on Emergency Medicine. And no, we're not going to talk about the best way to get an ultrasound and show cobblestoning or how to get that pesky apical view. We are really going to talk about the training that we are providing each other, the structure, the content, and how this is being implemented across the country. Before we get started, I did want to give a couple of quick updates for the AAP section on emergency medicine. EmergiQuiz submissions are now open until the end of the month. Submit your case now to Rashida Woods. I'm going to put the email address in the chat. PEMPICS, the visual diagnosis competition of the AAP section on emergency medicine. Submission period is opening soon. You're going to get some emails from Manisha Agarwal, the current chair, and Battle Royale 2, the pro wrestling themed education competition at the AAP Section on Emergency Medicine National Conference, is accepting nominations for 3 new competitors to compete against Alexandra the Great Cheatham, last year's champion. She will defend her championship here in Denver. So if you know a faculty member or colleague that is in their first 10 years out of training, you can nominate them or yourself today by emailing to babbleroyaleaap@gmail.com. I will put all that information in the chat. But for now, I'm going to pass the mic to our Master of Ceremonies, Ben Silva. The stage is yours.
Thanks, Brad. Honored to be here and looking forward to your personal appearance in a Lucha Libre mask and cape at the competition in Denver. So I am the co-fellowship director for our POCUS fellowship here in Houston, and super glad to be with you guys, and got some great speakers lined up today. And so we're looking forward to see what we can do about POCUS education nationwide, and if not worldwide. And just a quick note, I know the subtitle is Education, Implementation, and Quality Assurance. We're going to do a little switcheroo on you guys and make it Education, Quality Assurance, and Implementation, so that it'll flow a bit more smoothly. I'll tell you a bit more about our 3 presenters right before they do share with us, but just as a quick introduction, we have our first speaker, Dr. Jennifer Marin, as well to be followed by Dr. Patrick Trena, and then to finish off, Dr. Marjan Ghazi Askar, followed by a discussion where we'll have a chance to kind of discuss even further and open up to more questions. Although each speaker will have about 10 minutes for their presentation or so, and some time for Q&A following. So be sure to save your questions, submit them to our Q&A or to the chat, and we'll be looking forward to discussing those with y'all. I think without further ado, let's start with Dr. Jennifer Marin, who is our professor of pediatrics, emergency medicine, and radiology. She is the medical director of the hospital's POCUS program at UPMC Children's Hospital of Pittsburgh. Jennifer, without further ado, I will pull your slides up and let you take over.
Thank you. So I'm going to talk about point-of-care ultrasound applications. I'm going to refer to point-of-care ultrasound as POCUS now. Guidelines for PEM providers. Next slide. By way of disclosures, I do serve as a consultant for Ravana Medical, which is a medical device company. So when we talk about the various POCUS applications, it's important to understand that there are many. This slide gives you an idea of the scope of POCUS applications. And as the literature continues to grow, every year I feel like we see more and more applications for POCUS being used. For example, ultrasound is now being used by anesthesiologists and by some PEM providers. Perhaps you're using this in your shop to confirm gastric emptying prior to intubation or sedation. And also some providers use it in lieu of radiography to confirm G2 replacement. Next slide. So when we see this long list of potential applications, it can be overwhelming, and particularly to those programs that may be in their infancy. So how do we determine which ones to incorporate in our practice? My philosophy is that there is not a one-size-fits-all approach. I'm not going to tell you that you should be doing this, that, and the other applications where you practice in order to have a POCUS program. Next slide. The answer really is going to depend on where you're practicing and the answers to these questions. So first, what's the prevalence of disease where you practice? If you don't see a lot of patients with gallbladder disease, for example, there's not going to be a strong need to be competent in that application and perform right upper quadrant ultrasound on a regular basis. Becoming competent and maintaining competency in a specific application really does require a decent amount of pathology. So for example, at my shop, we don't see pregnant patients. So beyond doing a fetal heart rate, we're not doing first trimester pregnancies. Radiology services, they're going to be different depending on where you practice. Some sites don't have 24/7 ultrasound. So being competent in applications that are relied on to make diagnoses fairly routinely are going to be important for those PEM providers. For example, intussusception and appendicitis maybe. Does your site have trainees? The applications that trainees learn today may actually be different than those that faculty or staff providers need to be competent in for their practice. Is your site teaching other learners besides fellows, maybe emergency medicine residents, pediatrics residents, medical students? Each learner may have different needs. So for example, if you're teaching medical students, their curriculum may be geared more towards adult focus applications, and therefore there'll be more of a need to be competent in those applications. And finally, are you practicing in a low resource setting? The types of conditions and the disease processes that are most commonly seen in those settings will really guide which applications are important to be competent in. Next slide. So having said all that, there are guidelines that are available from various sources that tell us which applications are considered core to the practicing physician. And I'm going to go over those that are relative to general emergency medicine here. This is the list from the 2016 American College of Emergency Physicians policy statement, which was updated from their original 2008 policy statement on the use of ultrasound in the emergency department. These are the 12 core applications that they believe emergency physicians should be competent in. And of course, these aren't all necessarily even relevant in pediatric emergency medicine, right? We don't see AAAs, we don't see abdominal aortic aneurysms. And you could argue that DVTs are pretty rare in most pediatric emergency departments. Next slide. So looking at applications through a PEM-specific lens, it's important to know that the American Board of Pediatrics, the ABP, has taken note of POCUS. And as of 2009, this may surprise some of you, but as of 2009, they recognized POCUS as core content in pediatric emergency medicine. And these are the 4 applications that the ABP expects us to know: the FAST, cardiac exams, the evaluation of a soft tissue foreign body, and ectopic pregnancy. Next slide. Now, there are other sources of information regarding which applications are important in PEM. This was an expert consensus paper published in Pediatric Emergency Care in 2021, and it lists applications that are stratified by difficulty. So here you see what are considered more basic, easier exams technically to perform versus more advanced applications for PEM faculty. Next slide. This paper also goes on to recommend minimal numerical benchmarks for those that seek competency in a specific application. And you can see that the number is based on the technical and interpretive skill that's needed for each of the applications. So bladder volume, for example, is a pretty straightforward application. The recommendation is a minimum of 5 exams. Now, I don't want you to take from this that if you do 25 APPEs, you're going to be good to go. Or if you do 10 IVCs, you can do IVC without a problem. It's really important to understand that competency is an individual journey, and these benchmarks may not be relevant for every single learner. Some may require more scans, some may require less. And in addition, and it's discussed in this paper as well, the number of exams should not be used as the sole method to assess competency. So for example, I know of some programs, including our own, we use an OSCE type assessment. So that's a real-time observed assessment in order to deem learners as competent, in addition to the numerical benchmarks before granting privileges. Next slide. This was a paper out of Korea. So just to kind of compare and contrast different settings where you might be practicing POCUS. This also lists consensus recommendations for PEM physicians. And the authors here used a modified Delphi technique. There were 11 experts on the panel, and they defined consensus as at least 70% agreement. So this table shows you that there was 100% consensus on applications like appendicitis and testicular torsion. These are really different from some of the recommendations that come out of the US. Next slide. And this was a European study of pediatric physicians, so it wasn't limited to just PEM. PEM did represent about a third of respondents, and 22 European countries were represented. This figure shows data from the 340 respondents who said that they use POCUS in their practice routinely. And respondents ranked their perceived frequency of using POCUS for each of these applications on a Likert scale, and you see that Likert scale at the bottom. And what I did was I put blue arrows and blue stars to the right and left of each of the applications, which had the highest number of respondents that indicated they use POCUS almost always or most of the time. So this gives you a sense of what's being used most commonly among our partners in Europe. Next slide. This was the study of POCUS exams over 1 year in Malawi. So here we're looking at a low resource practice, and the table shows you the most common exams performed. And what I found most interesting about this study is that nearly 70% of the exams that they did showed positive findings. This is far beyond any positivity rate that we see in the United States. Next slide. And then this last study looked at what experts determined were core applications for PEM fellows, so programs that had pediatric emergency medicine fellowship training programs. And this was also a consensus-based study using a modified Delphi technique, 48 PEM physicians who had expertise in POCUS. And here consensus was defined as at least 80%. And they ranked an application as extremely or very important. So what we see here is that the FAST exam and evaluation for fluid around the heart, the lungs, cardiac function, pneumothorax evaluation, and soft tissue evaluation were really among the highest, ranked as extremely or very important. Last slide. In summary, there are many potential POCUS applications, and in order to determine which applications will be used in your setting, it's really important to understand what the needs and resources are where you're practicing. The literature is available as a guide, and it certainly can be used as a framework for those seeking to develop a POCUS program. And I'm happy to take any questions. Thank you.
Thank you, Jennifer. Simone or Brad, let me know if you see anything in the chat, although it's an applause reaction. Thank you, Rush. So I did have a question for you myself. How did you, and I'm sure this was maybe a multi-year process, but how did you assess those needs? Like you said, locally, was this a kind of yearly kind of thing? Do you continue to do something like that? Or like what method did you use aside from, unless it really was just asking everybody you saw?
Right. So I think part of it was just based on, I think, what resources we had available. So we have 24/7 ultrasound available. And I think that the applications that we have defined at our shop as being core applications for our faculty and what we trained our fellows, and those are slightly different. There is some overlap, but the curriculum that we have for our fellows is a little bit different and a little more expansive than what we have for our faculty. That has actually changed over the years. And I will say that there's definitely applications that have come and gone just based on our observation of how often patients are coming in with those scenarios. So one example would be kidney stones, gallbladder disease. That's something that we started, we were using, and then we realized when I started the program that we just weren't seeing a high enough prevalence of disease. And with 24/7 ultrasound available, it wasn't really high yield for us. And so we were focusing more on those applications that were making a difference at the point of care.
There, you bring up another question, faculty and fellow education. And I'd be curious to hear like your big differences that you've noticed, and maybe even specifically, let's see, how do we say this? More seasoned faculty who maybe didn't get the kind of focus training that seems to be becoming more ubiquitous nowadays. What do you find are big differences between those two?
I think that the more seasoned faculty, I love your term seasoned, Ben, have always been a very tough nut to crack. And I think there's just a proportion of our faculty who have been in practice for a while, who really never had any exposure to POCUS in their careers until more mid or later career, who are just never going to learn it and they're never going to adopt it. And I've made peace with that. I'd be very interested to hear what the other panelists and certainly what the audience, what their experience is. But I think our focus has moved to more those enthusiastic junior faculty and then certainly the fellows. And it is just routine now and part of their training. And I think that each of our specialties, pediatric emergency medicine we're talking about here, but I think it varies across specialty. And so, our pediatric urologists, every single one of them use point-of-care ultrasound in their practice every single day. So, because it was part of their training even before it was part of our training, which is fascinating to me. So I think when you take a more holistic view of pediatrics, it's also not a one-size-fits-all approach with respect to the specialty that you're talking about either.
Of specialties, Matt in the chat actually had a question about assessing the needs for other specialties, and then kind of helping those other hospitalists, NICU, PICU, et cetera, along in their journeys as well. Have you had? Go ahead.
Yeah, I assume the needs question is with respect to education and training. And I think this is probably a whole nother webinar about, hospital-based POCUS, but in terms of educational needs, my practice has always been that those fall on whoever's running that division's POCUS programs. We have POCUS leads, and in terms of education and competency and those kinds of aspects, the onus is really on that individual to determine what applications they need and how are they going to get that competency. And we're there to support that for sure. But I don't see, the role of PEM to train everyone in the hospital how to do POCUS. So that's been my philosophy.
Fair enough. All right, with that, why don't we transition over to our second speaker.
Thanks,
thank
everyone.
you, Dr. Marin, of course, and we'll be chatting a bit more at the end, of course. So give me a second to move on over.
Well, thanks everyone, and thanks, Dr. Marin. I'm Patrick, so I'll just say hi quick while Ben's getting the slides up. I am at Children's Wisconsin, which is in Milwaukee, affiliated with the Medical College of Wisconsin. We are a 3 fellow a year program, so 9 fellows, about 20 some faculty, some seasoned, some new, so not all credentialed, about half of the way there. And I was lucky enough to be asked to touch on quality assurance here and what works to maintain a POCUS program. And we kind of had a pre-meeting and went through some of this, and I think we're going to talk in broad strokes and probably echoing some of what Dr. Marin said in terms of knowing your institution and some flexibility in what your needs are, but kind of talking in broader strokes, and then hopefully that serves as a platform for some discussion. So if Ben, if you want to advance, that would be great. So things that I want to just touch on, kind of like Dr. Marin did as well, kind of what's out there in terms of QA guidance and documentation standards, and talk about some of the inherent flexibility that's out there too. We will go over what is POCUS middleware, and kind of talk about weighing some pros and cons with different approaches. We're not going to get into specific products per se. And then maybe this serves as a springboard to another discussion or some that we were just having about kind of what running a program in terms of engaging and leading on an institutional level. And there's been some movement that way as well. So, and we have some experience there. So happy to talk about that too, if we have time. All right, Ben, if you can move on, that'd be great. I have nothing to disclose. I've worked with several people here on the call to help develop some of their Epic-based POCUS infrastructure middleware, but nothing paid, and I'm not endorsing any particular product as far as a third-party middleware. You'll see some that I threw up there, just but nothing specific and no financial relationship. I think one thing, talking with Fred when I was asked to do this, one of the things I think we wanted to pull back and just look at is that QA is more than just capturing and assessing the quality of images obtained in clinical care. I think it's something that not only does that and it improves our patient and provider experience, but it also helps inform some of the training and credentialing process that Dr. Marin got into. We talk a bit about how do we build case logs in a transparent way, in assess competency. And so feeding some of this QA data can help when you work with the medical staff office and getting your providers credentialed. And we can talk about some other ways in terms of how QA can feed education, but it's all that plus more. And I think we all acknowledge that we should be getting credit for the work that we're doing and help float the bubble of revenue underneath this. And so aspects of QA and standards should be floating some of the sustainability of our programs. And so we want to design workflows that can make that happen. Next. So some friends on this call were leaders and instrumental in getting out a really important technical report and a joint policy statement with a few groups: AAP, SAEM, ACEP, WinFocus. And you'll see here some really important QA guidance when we kind of pull out that portion of the technical report, what's out there for guidance on QA. And I think we know that it's a minimum standard of quality of image acquisition and interpretation accuracy, and it should be done on a regular basis. And kind of a holistic review, we should have access to when formal imaging is done or outcomes data. We should be able to give timely feedback to our team and process. I think we were talking a little bit about this before the call came on, but having a process to handle the incidental findings when you're on shift and communicating those appropriately and documenting that. And I'm glad, and this has been a discussion, as far as how we support our ultrasound directors and dedicated personnel and calling for that role to be specifically supported. So I think two questions that come up in terms of QA that we might be thinking about is how often do we QA and the percentage of studies reviewed. And I think that, we have some guidance here, but it's not set in stone. And I think, in particular, at our institution, we have a mix of a lot of rotators, trainees, early learners, all the way up to a pretty experienced faculty that we're doing. And so we felt that in a program that has a mix of rotating new learners and not a crazy volume, that we do 100% QA. And we get back to providers within a day or two of their exam being done, if not same day. That may be completely different, that we may be dropping our percentage of studies reviewed if we're in more of a mix of a group in a community ED where we have established all credentialed clinical faculty who are very experienced with this. And so you might be looking at a QA mix of 10, 20% of scans. So it's not set in stone, but I think it has to match what you're trying to do with your program. And I think your risk tolerance as the ultrasound director taking this on. I think if there was one word that could sum up what could help maintain QA in a program, it's time. And I think we all acknowledge that. And so kind of advocating for our time is important. And what's going to make our time valuable is if we can develop a workflow that has efficiency in the QA. So if we can move to the next slide. One way to kind of make things hit from a documentation standards and also kind of being compliant with what we need out there for QA is, this came shortly thereafter, the technical and joint policy statements, this summary of evidence, which I've referred to a lot, particularly if anyone's thinking about starting a program, kind of assessing the evidence that's out there, what we know, what's yet to be learned, and also having really important accompanying reporting templates that can serve as standards. So hitting kind of all these marks here as far as what the guidance is for documentation standards for QA. And most importantly, not most importantly, but super important, is making sure that those images are permanently recorded as part of the medical record. Next. So we're going to talk about how we do that. And we're going to talk a little generally in terms of middleware, which is probably going to be synonymous with POCUS infrastructure that we can talk about. So we can move to the next slide. I try to think of this, you know, when we were building our thing, I think we try to think of middleware as an ecosystem. So I kind of center it around the patient and the provider, and we should be able to make connections across all these units. We should be able to work within the EMR to engage with providers and patients. We should be able to talk to the machine. We should be able to access and interpret our image on an archiving system like a PACS or VNA. And importantly, that administrative work that we need to be doing from quality review, we should be able to hit and easily access all those points. So building a system where these can talk efficiently to each other is the goal. I think the benefits of this, I think we all know it, but just to kind of call it out, we need to be able to streamline our work. We need to be able to get those images stored. We want to have high quality documentation standards and be transparent for credentialing, so we can call back and take a look at what our people are doing, and increase revenue and decrease some of that phantom, blind, or illiterate scanning that happens in the dark. Next slide. So I'd say there's probably two main options for a QA workflow. And like I said, this is broad strokes, but there's the EMR-based infrastructure, the homegrown. Mainly what I've seen is this has been out of Epic, or you can build it yourself, or you can go to a third-party middleware product. And I think there's benefits and disadvantages to both of those. From a homegrown one, and I think this talk itself could probably be a few hours. And I know we're kind of getting a little short on time, so I'm going to speed up. But pros for this is it tends to be cost effective. You're not hitting those ongoing subscription fees and costs of a third party company. And importantly, I think providers are already used to using the EMR that they're working in, so it's intuitive. It can be flexible and tailored. Again, some of the cons, it's a lot of heavy lifting up front. It's a lot of dedicated IS resource and time to plan this out and build it, but it can be done. So next. This is a good example if you want to look at the literature of a group in Connecticut that kind of outlined how they built and incorporated an Epic-based workflow system. So I'll reference that to you all. And then let's go next, because I have a quick video of ours, what this looks like in practice. This is about a 1-minute video. We use Imaging and Procedures Home off our track board. So we hit that there. Some of you may have seen this before. This is in a test environment, so this isn't production. Just these screen grabs. But when I go to QA, I'll look and I'll see studies in preliminary result that tells me that my providers have obtained images and documented and put in a preliminary interpretation. And so then I go into enter result to finalize it, and I'll see they're using those smart form documentation templates. I can access the images, review the chart from there. And then we go down to this reading form, which is all later searchable and reporting and drives the billing. And we can document our image quality. We can hit our accuracy of interpretation. We can kind of delineate if it meets credentialing criteria. We make note if there was a follow-up radiology performed ultrasound. And we've also added some comments banner, so this can go directly to a provider's in-basket. So they'll get that feedback. We sign that drops the billing and moves the exam status forward to final result. So if we can go to the next slide. that's just a quick virtual tour of how it goes. I know I'm running a little short on time. Third-party middleware, Synapse, I believe used to be Synchronicity through Fujifilm, QPath, AxoWorks is up there. I know GE does ReadyScan Go. There's definitely some vendors have built-in middleware workflow solutions too, so that's fine. It's convenient. It offloads the work of that build. It just is going to cost you money, and then there's going to be data sharing concerns potentially with your IS security. So it's a lift either way, but know that you can buy these products or you can build them yourselves. It's kind of the goal of this. We talked about how QA can support education. It's not just image review. I think you can do a few other things that we list here to help kind of foster POCUS education within your group and kind of couch it in QA. We built an educational scan, which is in a sensitive order class, but is meant to mirror clinical workflows. So getting people as they're training and learning to do things the right way and treating each exam with legitimacy, I think is important from a quality standpoint. And if you're looking to start a program or get support or advocate for yourself, sometimes using leveraging educational needs, a lot of the stuff that Dr. Marin just pointed out can be an impetus for leaders to kind of push these programs forward. I'm just going to point out that you're not alone, and we talked a little bit about system-wide POCUS work that's done and how we interact with that. I think it's important. I found it to be very beneficial. You can go to the next slide. I think for these reasons, patient safety organizations like ECR are pointing to this, that we should be doing this as well. So just for awareness out there that we don't have mandated standards for QA externally, but it is out there that this is on a potential hazard. So they've pointed that we should be working on a hospital kind of POCUS committee, and I won't read these all to you, but I think there's a lot of benefits here that can help inform those discussions. Matt, I think you talked about, how do we assess needs? This is a good way to start building these collaborative relationships, getting to your stakeholders early, knowing what's going to work with radiology, what are going to be the sticking points. These are where these conversations happen, and I think in a transparent way, it can help maintain a good program. All right, that's it. I'll take any questions, and thanks for your attention.
Thank you very much, Patrick. A couple questions from Munazi Rizvi. Number one, what's your relationship with radiology? Given specifically your images are in the EMR and the billing, yeah, how does that go?
It goes well. And these were the first meetings that I had early on, was to get to know our department, our radiology director, and some folks. This was on their radar. I think we've developed a really good relationship. We don't bill if there was a follow-up radiology performed ultrasound, then we don't double dip. We don't bill. We give up the ER billing. That was one of their kind of sticking points, and they wanted us to work through, like if we're doing abdominal imaging, like an intus or an appendicitis, we still needed to get a formal, which we agreed to. So there was some give and take. There was some negotiating. We were lucky that we have people who believe in it. They were able to carve out separate space for us on PACS. So I hope that answers your question, but it took a lot of meetings in person and trying to do things safely and coming from, doing things carefully.
Got a couple more. We've actually got a couple other questions here. I'm going to save those for our discussion later in the program and move on to our next speaker. Thank you so much, Dr. Drana. It could be a webinar or two in and of itself. So you did a great job keeping that as concise as you could. Okay. So we have Dr. Marjan Ghazi Eskar's slides up here. And give me just half a second. Okay, great. So she is our final speaker, and we'll be speaking to that implementation subtitle there. She's our clinical associate professor in the Department of Emergency Medicine, as well as the director of pediatric ultrasound education at Stanford University School of Medicine. It should be noted, she's got experience in POCUS curriculum development, including virtual implementation for the pre-upcoming attractions. And she also is an elected member of the POCUS and Pediatrics Leadership Committee within SOEM, as you may be aware of. So without further ado, Dr. Ghazi Asghar, it is yours.
Hi, Ben, thank you so much. That POCUS in Pediatrics is an SOEM, as you mentioned, within the AAP. Thank you so much. Really glad to be here. So the reason that we sort of changed the order of the speakers is because you guys heard the breadth of what types of education and really maintaining the program in order to have a POCUS, pediatric POCUS program. Next slide, please. So in order to do all of that, we needed a pediatric POCUS program directors, right? So I was asked to comment on what are the qualifications for such a person. And it takes a lot. And we just listened to the world of information that our two previous speakers spoke of. But some of the medical credentials, board certification both in pediatrics or pediatric subspecialty, current unrestricted medical license, active clinical practice with pediatric patients. In terms of training and certification, either formal POCUS training through a fellowship or dedicated courses or POCUS certification through really APCA's POCUS certification, which stands for Alliance of Physician Certification and Advancement. And then they should be able to have demonstrated competency in various pediatric POCUS applications. In terms of teaching experience in bedside POCUS education, demonstrating ability to teach POCUS techniques to learners at various levels, as it was mentioned before, and then some experience in curriculum development. Next slide, please. Our POCUS program director should also be able to have some administrative skills, prior leadership experience in medical education, understanding of the credentialing and the quality assurance processes, ability to coordinate with various hospital departments, radiology is being the main one, cardiology may be another one. They should have academic involvement in terms of research or scholarly activity related to pediatric POCUS, participation in some national POCUS organizations, and publication record is preferred. And these are based on the consensus practices. Next slide, please. I have put supporting references for each section of this talk so you guys don't have to go back and look at hundreds of references and wonder which one applied to which. So if you wanted to know a little bit more about pediatric POCUS program director's qualifications, these references are the ones that you probably are going to look through, and it'll help out with sorting those out. Next slide, please. So all of this, our great pediatric POCUS program director is going to do a good job, but they need time. And this is really important. And again, this is all expert recommendations or based on institutional experience. And I have included the references. So typically, such a person requires 0.2 to 0.3 FTE minimum for basic program administration. It may go up to 0.5 for programs with teaching more and multiple departments. And really the program size is a consideration, up to 0.5 FTE for larger programs. I've talked about the time distribution. Next slide, please. Really, we're going to divide the time that we talked about of these FTEs amongst four main areas. Administrative oversight and quality assurance image review are in this slide, which really consist of a combination of what we've heard so far. So managing the overall POCUS program, attending all of those admin meetings, budget management, equipment acquisition and their maintenance, coordination with other departments, and handling regulatory compliance on a regular basis. And in terms of quality assurance, reviewing our ultrasound images acquired by trainees and practitioners, providing timely feedback on image quality, ensuring their diagnostic accuracy, tracking and documenting competencies for our trainees, and also maintaining an image archival system. Next slide, please. So the other roles of the allocated FTEs are for education and training and also for program development. And they include teaching didactic sessions, conducting hands-on or virtual scan sessions, developing certain educational materials, supervising trainees during patient examinations and their scans, and really faculty development for other POCUS educators. The program development part of it is creating new POCUS applications, curricula and protocols, research on POCUS techniques and outcomes, expanding our program to sort of reach new departments if needed, people that do need help, developing credentialing pathways, and a strategic planning for program growth. Next slide, please. And again, these are the supporting references for the time references in terms of what a program director would require in terms of time. Thank you. Next slide, please. So while there's no standardized pediatric specific curriculum, I have spent a lot of time looking at the AAP's 2022 publication for POCUS in the NICU setting. And I think that this is important to realize that as the governing bodies for pediatrics in the US, how do they view POCUS? How do they view its education? I think it's very relevant to general curriculum development, implementation, and overcoming barriers. So a big theme is on specialty-specific policy statements rather than a universal curriculum that fits all. And we've referenced that before in our first speaker. Establishing dedicated training programs and really look at POCUS as a focused examination to answer a specific clinical question. And the theme that I'm going to go over and over, it's already been apparent and will continuously be touched upon, is collaboration relationships or collaborative relationships with other specialties and quality assurance and credentialing. You will hear us talk about this over and over and over again. Next slide, please. So I want you to just sort of consider the longitudinal design of a program. Next slide, please. And I'll touch on this a little bit later. So it is very important for implementation and for the sustainability of the program for the relationship to be very collaborative. And the practical application phases could really be, in the longitudinal sense, basic training, advanced training, and then clinical integration. Next slide, please. The assessment methods for the curriculum development could be pre and post knowledge testing, hands-on skill assessments, portfolio developments of saved images, or competency-based milestones and OSCEs. Next slide, please. Some of the success factors definitely come from protected time for training, faculty champions with dedicated FTE for them, adequate equipment access, quality assurance systems, and clear credentialing pathways. Next slide, please. So challenges to address really is the faculty developmental needs. And I know that Dr. Marin sort of is resigned to some of the older faculties or seasoned faculties, pardon me, not sort of buying into this. And I've said over and over again that we really just can't expect our trainees to do a good job if their teachers don't know at least as much as they do. So this is something that I am pretty passionate about, to hold the faculty developmental needs, ask other faculty what they need, hold sessions for them, hold workshops for them, in hopes of training our trainers. Integration of the curriculum into the existing curriculum is always a challenge. Time constraints for learners is another challenge. The credentialing process and ongoing assessment resources. Next slide, please. More specifically, and looking at the literature, really lack of trained faculty and supervision. 83% of people in this particular study felt that yes, it's agreed, it's needed. Only 67% provided it. Limited equipment access. There's no standardized pediatric specific curriculum. And I'm not just talking about PEM, but really segue into pediatric in particular. I'm a PEM person, but my trainees and people that rotate in the department consist of general pediatricians and pediatric residents. And really for the equity of delivery of care, I would like to hold them sort of accountable for as much as the EM folks at least can do at the bedside. Doing a fast is the bare minimum. And on a trauma patient, and a lot of our peds trainees really don't have the ability to do that. And so there are, for the other barriers, there are time constraints into a busy residency program, carving out enough time to do this. And then there's always the quality assurance challenges, the confidence issues because they don't do as much scans, and also interdisciplinary conflicts that we have to address. Next slide, please. Some success stories really come from longitudinal pediatric residency programs that show 61 to 90% improvement in POCUS comfort. PICU rotation is a popular one that really significantly improved knowledge of the folks that rotated through that rotation, did the elective. Cross-departmental collaboration, leveraging expertise from not only PEM, but our cardiology folks are awesome at this. The radiology folks are often awesome at this. The sonographers are wonderful. Our obstetrics folks have a lot of knowledge doing this. Dr. Marin mentioned urology folks are great at it. So we could learn from all of them so that it's not all just on PEM's shoulders. And really integration of adult POCUS educators to supplement PEDS faculty. Next slide, please. Some potential solutions really is standardized pediatric POCUS curriculum, cross-sectional, cross-institutional faculty development programs, as I touched upon before, implementing asynchronous learning opportunities, tele-ultrasound where you don't have educators readily available on site, mentorship networks, POCUS committees that are in really abundance now. They're very supportive, very collaborative, and really brings home that you're not alone in doing this, and you could rely on each other's shoulders to kind of create your program. Stakeholders to sort of create and establish funding for equipments and training, and create pediatric specific image libraries in collaboration with other departments or other institutions for learning and teaching. Next slide, please. I will tell you that the study that really sort of resonated with my approach was this collaborative credentialing, which really the approach included standardization across multiple hospitals, tiered credentialing levels, and clear pathways for both new and existing practitioners. And this is a way that they really are able to sustain their programs year after year with good results. Next slide, please. I have a few different resources on here that people could sort of learn online. They could, they're paid online courses. Next slide, please. And then just a sort of breadth of CME resources, different national organizations putting out sort of their own special courses or CME eligible activities that are on here for your review. And I think I'm done. Next slide, please. Yeah, these are some of the supporting references just for the curriculum development. And I think with that, I'm going to close and happy to answer any questions. Thank you.
Thank you so much, Dr. Gazieska.
Sure.
I actually, I've got a question for you, if you don't mind. Both you and Dr. Marin mentioned OSCEs, and taking me back to medical school. But I can appreciate how those would be super helpful in evaluating somebody's competency. Given using OSCEs to help establish what sounds like maybe credentialing in some specific areas, and the barriers that we've mentioned, how do you answer why for some of our faculty? There's a varying degree of enthusiasm amongst faculty. We've talked about the seasoned ones, so the junior faculty. And how do you find, or rather sow motivation amongst your faculty members for reaching and maintaining credentialing? And this can go for any one of our panelists or others in the audience.
So I'll take a stab at this. And can I don't know if you guys still see just the slides, or we need to get out of here maybe.
Slides, I can go back to a slide, or would you like me to stop
No,
sharing?
I guess I was saying that I can only see the slides. I can't see the audio. There you go. Okay. Sorry about that. So basically, in terms of so not everybody goes through the OSCEs is just one sort of avenue of sort of assessing competency that you could consider, right? In terms of the seasoned faculty, so and it's very different at every institution, but at our institution, as a part of a program director, there are numbers of scans and of number of scans that are acceptable that I have access to, right? So in order for you to maintain your privileges in performing and supervising trainees, every faculty member must be privileged and credentialed and maintain those privileges and credentialing. So after, for example, every 2 years where their privileges are coming up, we get a letter that Dr. So-and-so has X amount of scans, and on our shop, we require X amount. So then I email Dr. X and say, hi there, your sort of annual credentialing and privileges are coming up with the hospital, and this is the number of scans that you have. So you can either attend a QA, you can either participate in an OSCE, you could provide me with X number of scans just so that we could sign off on your numbers. So in my shop, that's how this gets done. And I love to hear other people's sort of approaches of how you maintain that, but that's how we do it. It's not just overwhelming, oh, let me come to you and learn everything I need to learn. It's a little bit of a, if you want to keep your privileges, this is what you need to have.
Ours is the same. Ours is
Yep.
very comparable. Yep.
Same.
Yeah.
Do y'all feel that you have difficulty with getting faculty members? Maybe I'm kind of re-asking the same question. I'm just thinking in my experience, I've had faculty members that are junior, maybe mid-career, and kind of have had maybe credentialing before and maybe let it lapse. Where do you, how do you encourage them to get back into it, so to speak?
So I'll take a stab at this. I think, there's probably a 1,000 answers to that question, and I think it's going to be a little bit different with each group. I think pointing to certain success stories, cases, is a really important one, right? Like we've probably all had the patient where we found a big cardiac effusion or poor function, and that completely changed what you were going to do, or you were going to stab into this abscess and it was a lymph node, or kind of highlighting success stories as to why it's important, I think is good. The other thing I'd get to, because I see as these junior faculty come in, and I think what we pointed to earlier is, your credentialing should have clear pathways for newly trained providers and then folks coming in with prior training. And so the mix of seasoned versus more junior faculty coming in with training, that's going to be changing year by year too. So I think there's a little bit of momentum that builds. I think you try and make it fun. We do scanning shifts, which, we bring in 2 or 3 fellows at a time. And sometimes we'll have faculty come in and join us. And it's a nice way for them to be in the department and not have to deal with the department. They can go around and scan and kind of bop in, bop out, and kind of the pressure's off a little bit, and they can get some case numbers. So I think there's got to be a visibility to it. I know that probably doesn't fully answer your question, but I thought I'd chime in.
I'll add that having buy-in and a presence from leadership can be really powerful. So our former chief and our current chief have made it a requirement of faculty to come to semi-annual training. So our POCUS director for the ED, she has training in the fall, she has training in the spring, and faculty have to sign up and come to it. And our division chief comes to it. And I think that does carry some weight as well. So having buy-in from leadership.
And also just one more point is I kind of just really felt that I was not able to undertake that because I just couldn't. And just like Jen said, I feel that, this is more than me. This is the hospital. So if you want to keep your privileges and you want to continue to have those privileges at Stanford and the prior institution that I was in, there's no choice. You have to have X number of scans in order for you to supervise trainees. And that's just the bottom line. Yes, at my institution, we do have mainly adult seeing providers that supervise EM residents, but so do we in PEM, right? So it's really a bigger force than me. It's just not only a leadership from the department, it's a leadership from the hospital. This is just how it is. And so I don't really have to, I try to make it fun. A lot of faculty like to come to scan shifts, but some people just don't love ultrasound. But if it's a requirement, I don't know how many people love to put a femoral line in on regular basis, in the ED or in pediatrics, but it's a thing that you got to do. It's a part of your job. And so the hospital sort of mandates it and we just carry it forward. So my job's a little easier.
Fair enough. Thanks for chiming in, y'all.
Yeah.
Number of questions coming in. And obviously, we're just going to head straight into kind of our moderated discussion, so to speak, and just kind of work through our questions here. Heading back up, there's some questions about the medical legal implications, and maybe more so for Dr. Drana or, of course, our other panelists, if you have experience, when you have ultrasound images in the EMR that maybe aren't finalized, and maybe, they have suboptimal views, your QA is just like, nope, doesn't meet credentialing criteria, and do they stay visible to everybody in that chart? And are people allowed? Well, I mean, the decision's probably already made. How do you guys handle that or feel about that?
Yeah, that's a good question, and something we didn't take lightly. And we met with compliance during this workflow and a bunch of different folks. The long and short of it is there are only people who are credentialed are putting in clinical scans for doing clinical medical decision making. So they have been credentialed, and so they have documentation living in the medical staff office. They've been signed off on, so they are putting in those real-time results. The prelim versus final is more of like closing out the billing and sending feedback. We are lucky that our group thus far has maintained. We monitor our false positive, false negative rates, that kind of thing. We're lucky to be under 0.5% for both of those. And so it's something that we monitor. I think the other feeling just culturally at our institution is we do have 24/7 ultrasound available as backup. So if there's any question or concern, we've been pretty clear with our group that if you feel like you're not confident with what you're seeing, get a formal one. So we get around it that way. But yeah, that prelim versus final deals a little bit more. Has the QA been closed out? And anyone who's putting in a clinically visible scan is going to be a credentialed provider with their name on it, and they have credentials and privileges in the medical staff office. So I hope that answers that question.
It does. I think it also answers another question about making decisions on preliminary interpretations. Like you said, folks who are doing this clinically are credentialed, and so they've already proven that they have that competency.
Right. And yeah, there's been times, just like a radiology study, there's been times where I see it the next day and we've had to talk to cardiology about something or call the family and say, hey, it wasn't clear what we saw here. You may need to come back or see this specialist or that kind of thing. So it's fortunately very rare. But so there's corrective processes in place, but yeah. Yeah, and Mitch, you're right. I don't know if prelims may be the appropriate term or not.
Just chime in and add that I agree with everything that Patrick said, and we have a similar process. If when we're doing QA and we have a calendar that has at least one person is on each day for QA. So, hopefully an ultrasound doesn't go more than 24 hours without being reviewed. And those that are in the medical record are only those that are done by a faculty member who is competent in that particular application. But we make mistakes as attending physicians all the time, physical exam, et cetera. So mistakes can be made by competent faculty when they're doing POCUS. So when we do our QA reviews, if there is an error or the exam is inadequate for whatever reason, we do call the family, as Patrick said, and then we will put in a note in the chart and say, as part of routine quality assurance, I reviewed the ultrasound and here's my interpretation and here's what I did about it.
That's a great point, Dr. Marin. Thanks for bringing that up. We had a question about, and actually I had one too, so we'll kind of tie this in with the Epic-based kind of, we'll call it middleware. Are you doing that both for clinical and educational scans, or just clinical? How do you handle those educational scans?
Yes, so the POCUS educational scan is in order you can put in. It mirrors the similar workflow. They have a similar swim diagram and stuff like that. It is something that's in a sensitive order class. So the way I like to think of it, so it's not broadly visible. So like, let's say you're on a scanning shift and you've been signed off as having like initial training, you're building a case log, you're a fellow, and you're on a scanning shift and you're doing the kid's there for a leg injury. If you do a cardiac scan, you'd order as a POCUS educational. We have banners on there that's like not for medical decision making. It'll be visible to people on the care treatment team for that visit. But if they go to sports medicine the next week, they're not going to be looking at an educational scan ultrasound report from the week prior in the ED. Not billable, not meant for medical decision making. It's for people training and POCUS towards credentialing or doing a scan that's not applicable to their chief complaint or medical decision making. But it's all something we can track.
Yeah, on a similar note, if you have a non-credentialed provider, i.e. a fellow doing a scan, and let's say they're working with a credentialed attending, does the attending have to fill everything out? Does the fellow fill things out and send it for a cosign to the attending? How does that work?
Yeah, so we have a field in terms of performing providers. We have the trainee there, and then we always list the supervising POCUS credentialed provider on the form. Got it.
That's a similar approach. We happen to use one of the third-party vendors, and they can be sent to the supervisor for sign-off. So good to know. Another, we're kind of going back in time here. So another question on the Epic-based solution. Let's say you built this out for the EC or the ER. Do other divisions, can they piggyback off that? Do they have to make their own build from scratch?
Yes, they can piggyback. it becomes a bit divergent. We kind of have two solutions that we push towards inpatient teams versus outpatient clinics. There is some tweaking they can do. In fact, our move to the PICU made a few more adjustments than we were expecting from the ED. So now we think we have a pretty good inpatient template that'll translate across a few of the other units that are doing it. So you can make adjustments, but we try to make it something that's easily pushed to other units.
Awesome. I think this goes for general for everybody. Had some questions about assessing scans, competency, like folks who are building competency. Do you all use any sort of objective assessment? So I can think of in our QA form here at Texas Children's, we have like it's a Likert score scale, but 3 would be like minimal, images obtained for like, what is it, minimum to meet to establish diagnosis. And then from there, 4 and 5 would be like excellent images, easily supported. Do y'all utilize any of that where you are to help track your trainees as they, and do you use that to assess competency?
Yes, we do. If you, on that video that we showed you, probably about half the way through, we kind of have that assessment of image quality on a 5-point scale, and then accuracy of interpretation. Those are all things that get logged in there. It's something you can go back and run reports on if you want. Actually, that's a great idea. I haven't gotten to the point of showing a fellow their scores over time. That's a really good idea. But some of that has implications for billing, just like, if they're a score a 1 or a 2, like that will automatically, the billing will fall off for that. Or if it was inaccurate, that kind of stuff.
So in a similar note, I'm familiar with QPath and also with the Butterfly sort of middleware, and there is a question sort of at the end: do these images meet requirements for credentialing? And if they're less than a 3, so just on that skill, there's no credit. So they could have done the scan, but they don't get credit towards their credentialing. So it's not considered towards their numbers. So when they come back and say, we did 50 DVTs, how come I'm not, credited? You can pull up that, and we usually send emails to the providers that, hey, you failed to visualize this, or your depth was this or that or the other. And so that's why you didn't get credit for this. And so we also use that feature, and I think it's very helpful. You can run a report of average scores of what their scans are. Graded, sort of. Graded, or whatever you want to call it. But yeah, we do that.
Looks like Matt has shared their color codes that they use in the chat if folks are looking for some additional ideas on that, objectively ranking things. More questions about educational scans. So are these visible to patients at all? Doesn't sound like it, but using the EPIC model, are they?
No, they're not. We do actually have a thank you note. We kind of consent the family to ahead of time. It goes through our health literacy committee too, that signed off on it, but we kind of explain ahead of time that what we're doing with educational scanning, the images get reviewed, we QA them all, that they're not getting billed for them, that we're not using them for medical decision making, it won't change their care. So hopefully that answers that question.
I think that does. And then in terms of, and this kind of ties into a question I had earlier as well, talking about QA, you mentioned the percent, trying to decide what percent of QA you want to do. You're at 100%. That sounded like you were talking about clinical exams. What about educational exams? Are the same folks, for instance, Dr. Marin, the folks that you have assigned for QA for that day, is that only for QA scans, or are they also doing educational scans that day?
We don't distinguish between them in QPath. I mean, we can, but we just review every scan that's been done since the last person reviewed, whether it's educational or not. And we can see if it's a exam for medical decision making. And so our feedback might differ if it's an exam for medical decision making and for some reason the exam is either technically poor or the interpretation is wrong, then we'll go through what I mentioned earlier, which is get in touch with whoever we need to get in touch with and then write a note in the chart. The other thing I wanted to mention was dovetailing on what Pat said. We have a macro in Cerner. We're going to be moving to Epic, but right now we're in Cerner, and we have a macro, which is just a template, which usually our fellows are the ones who are using for educational scans. And so it goes in the chart that the patient had an educational scan, but it doesn't say anything about the scan, the interpretation, what kind of scan it was or anything. It's just exactly what Pat said, which is I explained to the family that they were having an educational study. It will not be billed. It will not be in the medical record. If we find anything, we'll let your treating team know, et cetera. So it's very standardized approach. But so that documentation is there, but nothing else about the exam.
Yeah, it's kind of a similar question along the lines of incidental findings. I know we kind of addressed it a little earlier. You know, if something's found later, it may need to be addressed with family. If it's found immediately, I've had that happen to me a few times on our scanning shifts, and the primary teams aren't terribly excited about it, but it is what it is. And that's kind of my spiel when I talk to families about getting permission for this educational scan is if we find something that looks concerning to us, we'll let your team know and let them decide on how to address that. So other questions about faculty reimbursement. So somebody mentioned that as potential for incentivizing, kind of answering that why to maintain and get credentialed and maintain that. Or those maybe are there folks who take on extra educational opportunities or roles and responsibilities? Do y'all incentivize faculty? Have you thought about it? What's your dream?
Don't have this model anymore, but when we were getting bonuses for RVUs for meeting particular RVU benchmarks, faculty would get financial bonuses just for meeting those benchmarks. And so we leverage that by saying, like, if you do more POCUS, your RVUs will be higher and you'll get a higher bonus. We don't have those benchmarks anymore, so that doesn't work, but that does have potential if your shop uses those.
Yeah, we also don't use that particular model, but the bottom end, meaning it's not sort of individualized to the faculty, but if you are bringing in revenue because you're doing POCUS, that's money in the sort of the pocket of the department, and the excess money in the pocket of the department gets sprinkled amongst us at the end of the year. But it's not a thing that Marjan gets all the money because she does most of the POCUS. That's fortunately or unfortunately not how it works.
Yeah, I haven't quite gotten to that point of granularly distributing it to people, but what I have been mindful of is controlling the data. And so partnering with some of our financial analysts and the people in the business office to know running quarterly charges on all the POCUS reports and kind of knowing how much is coming in and what's getting reimbursed. So at least having that knowledge and kind of controlling that info, I think is an important first step to maybe having tougher discussions later on.
I think that's a great point. We've in COVID process, the person who was running our reports, and so we're trying to get back into that recently. And so having that data helps justify to your division chief, right? Maybe department chief, such for these discussions going back to FTE, right? We've had plenty of questions on FTE and how do you justify time for these responsibilities. And I thought it was an interesting model. I'll just comment, interviewed in San Antonio with their adult general ultrasound program, and they actually have their revenue comes back to their program, so their POCUS program, right? So it's not granular to each person, but their program, also gets to enjoy the resources or relies on maybe to get that deep into it, but that is one model that kind of focuses and gets you a little more narrow to the folks who are putting in that work, but also keeps it kind of in the system, so to speak. And it only took an hour and 15 minutes into our workshop for someone to bring up a question about AI. So, is there trepidation about AI for the validation of imaging, and especially in credentialing processes? So when do you guys think this is going to be good enough? Or is anybody using AI for credentialing or education or both?
We are not.
We actually are, there is a study including or about the AI model of a pediatric lung study that we are very, very excited about. And I think once we're very far away from saying that we're going to be okay with this forming or serving as a sort of a party that will say, yes, this is appropriate or adequate. But really, just like with anything else, it's a game changer. We're welcoming the study. We're willing to conduct the study and participate and look at the results. And these are novice providers that don't know anything about an ultrasound or how to do a lung ultrasound at all. So we'll see how it goes, and this is exactly what we're looking at. Whether or not maybe shooting ourselves in the foot, because I'll be out of a job, but yeah, I mean, we're looking at that to see what's the utility of this and whether or not it can perform that function. So we are open to it, but not anywhere near allowing AI to kind of come in with just for credentialing as a sole entity.
Did we lose Ben?
I know. I believe it caught him in a freeze frame. So I'm gonna jump in and allow you guys to give your final remarks to sort of wrap things up. Let's go in the order of our presentations. Jen, if you want to go first, then Patrick, then Marjan. Then we'll see if Ben jumps back in. But since we're heading up against time, final words from our esteemed panel. And then I'm going to bounce out because I just jumped in for like a half inning here. Ben can come back to the play-by-play. But go ahead, Jen, with your final thoughts.
My final thoughts, I think it takes a village. And so having as much support as you can from leadership, colleagues, other disciplines, the C-suite is tremendous. And the support of your colleagues around the country too, and talking to other programs. I remember when we started our program in 2010, I was on the phone with everyone I knew who had a POCUS program. So it's a wonderful group as testimony, this webinar is testimony to that. And so we're always available to help answer questions or guide anyone who needs it.
Yeah, I would echo that. I'm probably a relative newcomer here, but I really appreciate the opportunity to contribute, and I really enjoyed the questions, so thank you. I agree that this is something that we all know takes a lot of work. And I think the relationships you build at the institution are really, really important to driving the success. So to pay close attention to that. I think, we did go over a lot of the basics of QA workflows and stuff. I think there's definitely an appetite to probably dig into that more. And I've spoken with several with you, but I'm always available to bounce ideas off of, and you guys help me think of things that I haven't thought of. So I think that's always an ongoing discussion, and I really appreciate you guys having me here to talk.
Hi, I just, you guys should reach out with any questions. I'm so thrilled that there's so many people that are interested in this. And I think really for me, collaboration is the name of the game. You can't do this by yourself. And it can be pretty lonely if you're sort of the cheerleader for POCUS without a lot of other buy-in. So reach out, join the POCUS committees, whether it's nationally or in your institution, and just reach out. We're here to help, and it was a pleasure to be here. Thanks for having me.
Thank you so much to our speakers and our audience participation.
I think everybody did a great job in demonstrating that each one of these topics deserves their own workshops. But I also think that we were able to get across a lot of information and hopefully a great overview for everybody. Know that we, our speakers and other folks in POCUS and Pediatrics interest group are more than willing to help get things going off the ground, soaring higher than ever before at your program, whatever you need. We're happy to help with that. Thank you, Brad, for helping organize this, Simone as well. And with that, I think we can bid adieu. Have a great day, everybody. Happy scanning.
Thanks, everyone.
Thank you.